Hi, everyone. Thank you for joining us today. My name is Lippy Doshi, and I'm the co-chair of Social Media for Global Health. I'll be moderating today along with my co-chair, Ann Cott. We're going to get started with introductions while we wait for others to join us. Social Media for Global Health is an online community of more than 1,000 members from 45 different countries. We provide a space for professionals to share their experiences with social media to promote health messages, programs, and the impact of global health and development organizations. If you're not already a member, I encourage you to join us. You can see a link to do so on the screen right now, and you can also follow us on Twitter at SM4GH if you're interested in social media, job, and professional development opportunities. Our speaker today is Dr. Christoph Pimmer. Christoph brings more than 15 years of experience in digital learning, collaboration, and knowledge processes with a particular interest in the fields of global and public health. Christoph acted as a visiting researcher at UCL Institute of Education in London and at the Columbia University in New York. He currently works at the University of Applied Sciences and Arts, Northwestern Switzerland. I'm very excited for the webinar we have planned for you today. For the first time, we'll be talking about WhatsApp. With over 1.5 billion users in 180 countries, WhatsApp is the most popular messaging app in the world. Everyone is on it, I'm sure you're on it, and so are health workers. So how has WhatsApp been used on the front lines of global health, and how should it be used? Christoph will share examples of successes and tricks of the trade from a study of the use of moderated WhatsApp groups in more than 1,500 nurses and midwives in Nigeria, Zambia, and South Africa. Before I turn it over to Christoph, just a bit of housekeeping. This webinar will last approximately 1 hour. Anne and I will be moderating the chat box that you see on the screen. If you have questions for Christoph, please type them in the chat box as you follow along. We will be collecting them for a Q&A period at the end of the presentation. Please also introduce yourself in the chat box. It looks like we have quite a few people today, which is really great. We'd love to know who you are and where you're coming from. And finally, we will be recording the webinar, and this will be posted on the K4Health YouTube in the coming weeks. With that, over to you, Christoph.
Thank you very much for the kind introduction, Lippy, and welcome to everybody. I'm very pleased to be here and to share with you this morning or this afternoon the experience that we have generated over the last 5-6 years regarding the use of WhatsApp to better connect, support, educate, train, and perhaps more generally speaking, empower health workers. We have been working in particular with nurses, but also with community health workers, and some of the experience that I will report today will relate to this project. So it will be a summary of several projects from across a range of countries, including Nigeria, Zambia, South Africa, and also Malawi, in which I worked with community health workers. So perhaps before I go into the details, a quick overview of what I would like to share today. I've planned to start by outlining the high popularity of WhatsApp by health professionals before I then discuss some of the benefits that we have identified through our research, benefits that arise from very different usage or user contexts, from informal use, for example, students who learn in placements by using WhatsApp, but benefits also that we obtained by implementing moderated WhatsApp groups, as you, Lippy, you have already announced that. And then from the third case, I would like to report about how we used WhatsApp to coordinate community health workers. And this study of this innovative project is from Malawi. One thing is absolutely key, and this is the moderation facilitation, because the effects and effectiveness of a WhatsApp group stands and falls with the quality of the moderation facilitation. And I'm happy to share some of the lessons, some of the insights that we have gained over the last 6 years. And while there are admittedly a great number of benefits when it comes to the use of instant messaging, perhaps more in general, there is also a flip side. So there are risks and challenges which are linked particularly to the inappropriate use of instant messaging and social media more in general. And we did 3 things. First, we tried to systematize them. then we developed guidelines, recommendations, for example, together with the Zambian Council for Nurses. And we also developed quite simple, but we still hope that they are effective e-tutorials, mobile tutorials. So this is a quick overview. Of course, you see that each of these points would perhaps warrant an individual webinar, but I try to do my best to share some of the key points and other things we may perhaps then touch on in the subsequent discussion. But I would like really to start to outline how WhatsApp is being in use and why we've actually decided to use WhatsApp also in our research and innovation project. And the thing is, we didn't go into this project context with the fixed idea that we would use WhatsApp, but we asked health professionals, nurses, for example, and others, what is the main tool that you use? And the answer was in the very different contexts, particularly when we asked our nurses, WhatsApp, not just for private, but for a whole range of professional purposes, and just example categories, team and resource management to coordinate the drug logistics, for example, but also to host further education in informal learning opportunities. For example, in Zambia, nurses and midwives came together in WhatsApp and they discussed professional issues, and by contributing to these discussions, they could get credits which then were accounted for, or which then accounted for their continuing professional development. And then, of course, there is a great range of different expert groups. I've listed some examples here: nurse educators or mental health nurses, which form around different areas or disciplines, including sometimes international groups or interdisciplinary groups. So WhatsApp is really very widely used, and we really wanted to leverage resources which are already in the hands of health professionals, nurses and midwives, the 3 countries in which we have been working, because this is very relevant when it comes to scalability and sustainability, because I would argue that many of our interventions that we have carried out, and we have been working over the last years with thousands of nurses and midwives, can be easily brought into other contexts and replicated there. Perhaps it's worth mentioning that for none of our interventions or of our activities we provided any financial compensation. So as the entire participation was voluntary, the whole initiative was really driven by the intrinsic interest by our participants. And this, I think, is quite interesting and quite telling. And along similar lines, we used WhatsApp because it was a very low threshold tool. We hardly ever have come across the need to provide any technical support. And perhaps one aspect that we have come across in some settings, when nurses or other health professionals had problems with their WhatsApp, they just asked their children or their neighbors' children, and so most things could be sorted out. Now let's move over to the benefits, and we started by trying to understand what kind of benefits in terms of educational benefits, professional benefits might be associated with the use of WhatsApp without any intervention, just benefits that arise from the informal use. And we carried out a study inter alia in Nigeria, from which I've taken the results here, to use, and we used the case of placement learning, which is a central stage of development for nurses or nurse students. And we compared different media: WhatsApp, Facebook, SMS, and email, all of which are quite popular in the respective context. And the results that we have found are quite interesting because, first of all, WhatsApp was used more frequently than the others. So SMS was popular too, but WhatsApp was the most popular tool. And then WhatsApp was also considered to be the most beneficial platform in terms of educational and or professional benefits during these placements. And then we ran some statistical analysis, and we found that WhatsApp use correlated with a number of relevant socio-professional indicators, which means, for example, the nurses who used, or nurse students who used WhatsApp more intensively at the same time also had higher levels of resilience, better transfer of school knowledge into practice, high levels of professional identity, and even a better or higher placement satisfaction, which I think is quite remarkable. Of course, we cannot confound here causation with correlation, but still it's quite indicative of the value that WhatsApp as associated with, and we found particular strong connections with resilience, which means that WhatsApp use, according to the regression analysis that we have been running, also really predicts learners' level of resilience or nurses' levels of resilience, which is quite interesting because resilience is a very important construct for health professionals. In other words, WhatsApp can support users' ability to cope with more stressful situations that they might encounter in their work. The second case is about the systematic use of moderated WhatsApp groups, and we wanted to take the whole thing one step further and to see, can we really leverage the benefits a bit more systematically by having moderated WhatsApp groups. And we selected one of the most critical phases of development that health professionals in general have to undergo, which is the school to work transition, which means when health professionals are in the first month of their new job after graduation, a highly challenging phase, which is decisive for the further career and professional development. And what we did was to set up moderated WhatsApp groups in which we reconnected these new graduates with former classmates in groups of about 20 to 35 persons. And we engaged moderators who were professional nurses for the duration of 2 to 6 months, depending on the different contexts. And the moderator did nothing else than providing relevant knowledge regarding two aspects. First, clinical knowledge, for example, refresher and updates about communicable diseases, or professional knowledge, an example being how to deal with high levels of workload stress or interprofessional conflicts, or to engage in discussions about professional development and career development opportunities. And another aspect which was very relevant was the provision of support on demand, not just the moderator, but by the entire peer community, so to say, in situations of need. So these young graduates, they found themselves in difficult situations, and having the group as an enabler or provider of socio-emotional support was something very relevant. And the results, I think, they speak for themselves. So compared to control group, the WhatsApp groups had higher levels of knowledge. We measured this by using tests, by applying tests. They had increased resilience and reduced professional isolation. In consideration of these results, I think it's worth trying to understand what kind of mechanism are bringing forward these particular benefits. And I think in essence, WhatsApp does better than other media enable intimacy, meaning that we can use WhatsApp to reconnect with bonds, with social connections who we trust. Immediacy, which is, we know all the word instant messaging, so we get instant support, is of course in many professional contexts highly relevant. And ownership, other than, let's say, a knowledge management or an e-learning platform, WhatsApp is really a tool owned by the frontline health workers, and this is another part of its success. The third case where we studied the benefits leads us to Malawi, and there we worked with community health workers and their supervisors. These groups were already equipped with smartphones, but we enabled WhatsApp, and the basic, very exploratory question that we pursued was, how would this group of supervisors and community health workers use WhatsApp to organize or to manage their work? And we did an observational study, and generally it became very clear that WhatsApp was frequently used and it was very well received. And we find two different, let's say, groups of usage. First of all, WhatsApp was very clearly used to accomplish instrumental purposes, like task-related purposes, mobilizing, for example, material or human resources, organizing measles campaigns, organizing the distribution of malaria drugs are just two examples. The supervisors use these tools also to manage their teams, particularly to visualize and to acknowledge their performance. So as a source of transparency and motivation, in other words. And this third instrumental purpose is also interesting because particularly through the instant nature of WhatsApp, the health workers had another opportunity to involve the team, their supervisors, if they encountered more difficult, more complex patient cases and ask for their advice. And all this has led to enhanced manageability of a, let's say, quite geographically distributed health workforce. And there were also participatory or social benefits, which basically speaking enabled this community of community health workers to engage in a community of practice, which enhanced their connectedness and was very relevant because health workers, community health workers, tend to be a group which is professionally isolated. I think the statement on the next page, and I would like to let you read through this, quite nicely illustrates the point about professional connectedness. I give you 15 seconds to read through this. Well, I already mentioned that the effects and effectiveness, or in other words, the success of a WhatsApp group stands and falls with the ability and skills of the moderator. And we know a lot about moderation from classic forms from classic media, but with instant messaging and social media, moderation is different, and it's also different with regard to, let's say, frontline health workers or perhaps global health workers. So what I'm trying to share now is some of the insights that we gained over the last years, over the many interventions, which helped us to better moderate and facilitate our participants. And of course, we will be coming up with a full report, and I can only mention some details, so I really can't, I'm not able to go much into all details. But one thing which is very relevant is that WhatsApp moderation or instant messaging moderation needs much more guidance than perhaps discussions on other media platforms who tend to be much more structured would need. To put it very bluntly, in WhatsApp, all the communication goes down in one tube, and this can lead to disorientation, which means that in many respects, moderators really need to provide orientation. And this starts with the development of the ground rules at the beginning that we highly recommend the group before they engage to really discuss what's the scope, what should we discuss exactly and not, and when should we engage. For example, some groups say we only want to discuss between 5 and 7 or 8 in the evening. WhatsApp can be very intrusive when some people start communicating after midnight, for example, and also a bit about what's an etiquette, for example. And so the moderator needs to coordinate this development of ground rules, and then throughout the entire process, he or she needs to provide extensive orientation, much more than in other media platforms, that, as I already mentioned. So where are we? What are we doing next? What have we achieved already? He or she should provide deadlines and really keep the focus, or help keeping the group to stay focused. And this is also true for topical versus social conversations, because WhatsApp and instant messaging or social media in general, these are inherently social tools, and people are not used to really engage in topical or actual discussions there. And what we found out, it's not helpful at all to try to keep the social aspect outside of the group. So moderators have to strike a very fine balance between keeping the group focused and, on the other hand, really allowing a certain level of social presence, because this is absolutely essential, a co-product and an absolute influencing factors to effective engagement, but not letting social discussion become too intensive, because then it's all about football or birthdays or weddings or car accidents or whatsoever turns up. Well, and one thing that has worked very well is to really engage local moderators or local influencers from the very beginning. And this can start, or should start, already with the setup of the group. Not let a global health professionals set up the group, but look who is an influencer, who is a moderator. There are some naturally born moderators on at the front line, and try to leverage this, so to say, capital which is out there, or at least have co-moderation, local, global, which is then hopefully quickly handed over to the local forces. And one thing which is also relevant is to train moderators. You don't need to have extensive training, but really prepare moderators in a 3 to 4 hour workshop, what they should do, how they can engage in active participants. This is something which is really necessary. And what has helped us also in many aspects was that putting together moderators in a separate WhatsApp group where they can discuss different strategies, share experiences. This is something that they also found very relevant. And I want to say a couple of words about instructional content, because in many projects we want to use, or we are inclined to use WhatsApp as a knowledge tool, share relevant clinical guidelines, refresh your knowledge, and so on. And generally speaking, WhatsApp is not a good tool to share knowledge by the book, or to convey large amounts of knowledge. So if so, it has to be absolutely concise and short, key content. And there's something that we also found helpful and that we would recommend, is to share key knowledge in terms of infographics, PDFs, because this is something that the participants can much more easily retrieve also at a later point in time, so they don't need to scroll up and down endlessly to search different pieces of information. And one other thing which has worked very well in our settings was the very use of gamification, of simple gamification mechanisms. So we discussed a different topic each week, for example, in Nigeria, and the week each week was concluded with a quiz, and the winner of the quiz, of the knowledge quiz was then rewarded with a bundle of airtime, which was not much, but it triggered incredible engagement, and we conceived this to be some of the relevant influencing factors. Another thing that has really worked very well is instead of sharing knowledge by the book, it's very good to engage participants in practice-oriented reflection. So reflective questions regarding have you carried out this procedure, this medical, clinical, or whatsoever procedure already? What's your experience? When nurses or health workers can relate with their own experience to the topic, then the discussions are much richer, much more fruitful, and there's a lot of learning involved in that. And we also used scenarios to do so. So particularly in the South African context, the participants provided with scenarios. Imagine you would be a nurse in that situation. What would you do? So providing quite an authentic learning scenario also triggers rich forms of engagement. Well, we have been discussing now, or I have been sharing insights about the benefits and how we can enable them. There's also a flip side which we cannot and should not ignore, and this is that there is a lot of inappropriate non-professional use out there, and we did actually three things. First, we wanted to systematize different risks, and then we tried to address them by coming up with guidelines and recommendations, and we also developed, as I mentioned, an or mobile tutorial, which is very simple, but I sense, without having that rigorously evaluated, it is effective. But let me start by highlighting some of the problem areas. One which is particularly evident is that in many instances on social media and WhatsApp or instant messaging platforms, clients' right to privacy and confidentiality has been breached by just sharing information which reveals, for example, the client's identity. And we have come across many instances, and I think I just wanted to let you read through the following quote, which is very telling and which is nicely exemplifying the very negative consequences that just such a behavior can have. So this is just one out of many examples that we have found and heard in the focus groups and discussions that we have had, and which needs to be part of training and guidelines. Then the second category, which is also quite well known, is that instant messaging and social media in general, they are a source of misinformation, false information, fake news. They are, in other words, echo chamber for this kind of misleading and wrong information. And this is also something which is a relevant part of mobile social media literacy, as I would say it. And I will share with you just one example, because such information is particularly negative or devastating in the situation of crisis, such as the Ebola crisis. I'm just providing you with one information that was circulated, I think, in Nigeria, and this is a source from BBC Trending, but we came across the others also in our workshop. Two things: health workers, health professionals are not immune to sharing misinformation, fake news, and this is why we absolutely need to enable them to be at the forefront of fighting health-related misinformation. And there are several measures, but very generally speaking, I think that this is a skill which needs to be embedded in all kind of training curricula, because it is as probably as relevant as many other forms of clinical, medical, or professional knowledge. And another thing which is, or which we thought would be a very relevant problem area is a distraction and client disregard, which is caused by the use of mobile apps, by mobile apps in general. But as we know that instant messaging and social media can be particularly intrusive or addictive, these are tools which are probably make the situation worse. This can lead to clinical errors, medical errors, and also to disregard of patients. And I will show you, I'm showing you now the final quote, which should exemplify this problem. And this is also something that needs to be put into the education and needs to be regulated. And in some of the contexts, such behavior has not been regulated to date. There are many more examples of this, and we have developed a report with more problem areas, more examples, and based on these examples, we have developed recommendations and guidelines. And you can download this report using the links, which are displayed in this presentation. Drawing on that report and on all our experience, we have also developed guidelines regarding the professional use of social media and particularly instant messaging for Zambian nurses and midwives in close cooperation with the Zambian Council for Nurses and Midwives. And you can also download the guidelines. And I already indicated that there's also an e-tutorial, a very simple one, but I think it at least comes to sensitize people and to help health workers develop what I would label a social mobile media professionalism. There would be many things to include, so this can be, of course, expanded. The tutorial draws on the Zambian guidelines and, of course, on all our experience that we have gained in different contexts. And I think one of the features that I would like to highlight is that it is scenario-based, which means that the users, the learners, can put themselves in scenarios and ask themselves how would they react in a particular situation. So we try to make that learning a bit more authentic. Well, then perhaps a couple of considerations regarding next steps. We are now, as you can see and hear, in the midst of our dissemination process. So we are not trying to withhold our findings, but we are very happy to share all what we have learned. Although many of our research interventions are still up and running, and many things are still in development. But there are three main areas of what we can think of next steps. So one thing is really support the scaling up of same or similar approaches in the areas in which we have been working, which includes training, placement learning, school to work transition, or let's say the support of new graduates and others. And what we would be also interesting is to expand the research a bit and to understand how instant messaging, which is such a relevant and widely used tool, is used in other contexts. For example, we are about to set up a research project with Johns Hopkins School of Nursing regarding the use of WhatsApp in Nigerian hospitals as a clinical tool for cooperation and clinical management. And this is just being one example of how this work can be expanded. And let's say a somewhat different strand where I'm working at the moment with colleagues from my own institute who are AI researchers, is to develop artificially intelligence-based chatbots, which can then help to supervise and guide, train health workers or even clients. And we have started with our work also in this field. So if you see any synergies, common interests. So we might explore also some forms of potential collaboration. Well, here's a summary of some of the practice resources, the practice deliverables I've been talking about, most of which you can download from our website, which you find here, socialmediaforhealth.net. And this is the place where you can also find the empirical studies, which are underpinning many things that I have been sharing with you now. Of course, there are many more publications in the pipeline. And I would like to finally highlight the Research Consortium with whom we have been working, which is made up of teams from the University of Ibadan, the University of the Western Cape, and the University of Syria. And we are also, of course, very grateful to our funder, which is the Swiss Program for Research on Global Issues for Development. Well, these are some of the faces, not all of them, but some of the faces who have contributed to this research and innovation effort. And last but not least, here are some contact details, just in case you want to have further information. We have some papers, for example, where we have the pre-publication version, which are not, however, published yet by the journals. We're happy to share also this if need should be. Well, I think I've been talking a lot, perhaps too much. Now we certainly have time for some questions. Again, I only was able to touch briefly on some of this. Much more discussion would be and is necessary for some of the topics that I've, or for nearly all of the topics that I've mentioned. But perhaps we can cover some of the issues now in the discussion, and we also might have discussions in the future continuing with some of these topics. Thank you a lot for listening, and now I'm happy to answer to the question.
Thank you so much, Christoph. That was a fascinating presentation, and I think the audience agrees. We've had so many questions come in. So let me quickly jump into them so that we have time to cover as many as possible. The first question, something you touched on, is that WhatsApp has come under fire for being a source of misinformation and fake news. And you talked a little bit about that at the big picture level, but this question is, what are the best ways to combat incorrect information within a WhatsApp moderated group? And one audience member, Gurpreet, mentioned that they've seen misinformation chain messages, including myths about menstruation and hygiene products through WhatsApp. So in those types of situations, what's the best way to manage it in a moderated group?
Mm-hmm. Thank you for this. And this is an absolutely relevant question, because WhatsApp has really turned out to be a main instrument for sharing misinformation. Perhaps first I want to highlight why WhatsApp is so powerful, and unfortunately so powerful in sharing misinformation, because more than other platforms, WhatsApp enables us to engage with bonds, with strong social connections, with whom we trust, and from which we sometimes tend to view the information that we get much less critically than we would do so from other sources, and this makes us so prone to errors, to misinformation. And I think, as I already pointed to, we need to start much earlier than just in the WhatsApp groups. We need to enable our health workforce to really be able to identify such forms of misinformation. So this needs to be embedded in all kind of training, and we have some very promising instructional methods, online or offline, how to do so, because what's very helpful is to in a way to prime users with fake news, or even to put them in the role of fake news creators. So then they are much less likely to uncritically consume misinformation. So this needs to start much, much earlier. And by the way, we are very interested. We have some ideas and plans about how to develop training to really better enable health workers and to protect them against, let's say, consuming and sharing fake news and misinformation. So we would be interested in this also. In a group, coming back to your question, I think the moderator again takes a central role here in that he or she needs really to make participants aware of the criticality that they have to show towards general messages which are being shared on social media and WhatsApp in particular. So just the fact stating that, let's say, 40% of all information shared on WhatsApp is plainly wrong is something that can be shared. And this culture of criticality need to be let's say, enacted by the moderator. Questioning information, for example, which comes from outside, which is being forwarded, which is being shared, asking people where the information from, going on respective websites, from the ministries of health, from the World Health Organization, just questioning the information, trying to verify is one step, which is sometimes quite cumbersome, but it's something that really needs to be part of a moderator's task, or of a good moderator's tasks. It has to be then also be this has to be a culture or be part of the culture of the group. And yeah, so I think what always helps very nicely is if I put the information that I get into Google, and Google returns, if it's misinformation, then turns results which are pointing at this piece of information being wrong. So Googling it or using another search machine to verify that misinformation is a very simple but effective step.
That's really helpful. So it seems like overall, as health workers and moderators, to be critical of the information, and also to be observant of the source of the information. And hopefully, some in the future they'll be fact checking within WhatsApp to make this even better. The next question is a big picture question. This one is with WhatsApp being the most reliable and cost-effective network for international messaging, and like you said, so many of us use WhatsApp personally and professionally, especially in the international development field. Outside of your city, where else do you think WhatsApp could be used in global health? Could it be used for advocacy, support groups? What do you think?
Mm-hmm. I think that there's hardly any area in which WhatsApp is not being used right now. So what we have seen, it's used in all different levels of medical, clinical, health-related, global health-related activities. So I think it's already used very broadly, and I think so we take inspiration from context and settings in which it is already used, and we carried out a survey in one of the papers, I think is also mentioned, where we tried to study the use of WhatsApp in the field of global health, and the paper is entitled New Knowledge Tools in Global Health, and it has been published in the journal Knowledge Management and E-Learning. And I think one of the key outcomes of this admittedly selective, so not very representative survey is how that one of the key features of WhatsApp is its low threshold and its boundary crossing nature. Means that it can, better than other tools, connect and bring together local and global health workers, health professionals, also different professions. And I think it's a very good tool to getting a better glimpse for project offices of what's going on the ground, obtaining local views, better using and leveraging local knowledge. I think this is a very general area, so it can be applied to many different settings and contexts, but I think this is something where WhatsApp can be really used nicely. And of course, it's not a one-size-fits-all tool, and when we bring WhatsApp into further contexts, I think that we always need to be aware of its nature. So it's a grassroots and a peer medium, and I think it is most effective in really supporting grassroots and peer communication. For example, self-help group, peer moderated, or let's say all kind of facilitated peer exchanges involving clients are something I would regard as very promising. And I mean, the question is really very broad, so, but I want to add one other thing, which is connecting AI and conversational artificial intelligence with instant messaging. This is another very promising avenue. Is it via written chats or via audio? This is something where I see great potential, particularly regarding the supervision, guidance, training, management of individuals, but also of groups. And this is where we have started some projects recently. So,
Wow.
well,
Yeah, an AI component would be really fascinating, and I agree that WhatsApp really does open the local side of work, and that's so important. Global health, global development depends so much on strong health systems, and they're carried by health professionals, health workers. So it's an amazing grassroots tool, and I think we described it very well. I received quite a few questions about the study itself, so I'll just clump them together. Um, the question is, how did you evaluate the activity specifically? How did you compare users to non-users or indifferent users? And what was the control group? And then adding on to that, what variables did you control for? Income, location, and did you see differences between male and female users?
okay, so the thing is, it's not one study, it's about, I would say 10, 12, or at the end, I think, come up with 20 studies. So hard to say that. So we used randomized trials, so that I think should answer the question about the control groups. In our regression analysis, where we studied, for example, the informal use, I think we controlled for all kinds of socio-professional variables, including age, gender, the region in which these professionals were working. Yeah, so we had so many different research designs, which makes it a bit hard to evaluate these, to give a general answer to these questions. What I think is very, very telling is also to not just to measure like this psychometric outcomes or knowledge that these nurses would have, but really to take a look at the actual WhatsApp conversation, because they are often very telling. What's going on? Who is engaged? To what extent? How is the moderation being? So really taking a look at how learning and knowledge sharing is being co-constructed is a variable. Is a very valuable approach to study this phenomenon. But I'm very happy to answer methodological questions a bit more in detail, and they might come up if you study all the papers that I have put on the web page. Of course, each approach, if qualitative or quantitative, has weaknesses, limitations, but in really trying to triangulating our methodological repertoire using really very different methods to understand a similar or the same phenomenon, we got valuable insight.
Thank you, and thanks to Kate, Avery, and Reese for sending in those questions. And I believe your video is available for the audience to read more about. Is that right?
Yes, there are. There are studies. All studies are available. So at least the pre-publications, which is basically the same content, and we have made them available on our website. There are, however, I would say 5 to 6 forthcoming publications where we have only carried out data analysis, and all these will be made public in the next 1 to 2 years. Unfortunately, the publication process is somewhat lengthy and awkward at times. So whenever we have a pre-publication ready, or whenever you are interested in a particular aspect in a particular study, we are very happy to share the pre-publication, or even giving insight into first results, for example, from a statistical analysis.
Okay, thank you. This question is from Anne. WhatsApp limits groups to 200 members. For those of us joining who are interested in training large numbers of professionals at a time, can you share your thoughts on the group limit in the context of training?
That's a very good question, and we have really tried to answer this question for ourselves. And my answer would be, depends very much on the kind of training and the kind of group activity you want to have. If the training is only about, let's say, communicating facts, guidelines, whatever, then you can really use the full, I think, nearly 200 participants. But if there should be any social interaction, social kind of learning, group reflection, all the benefits that the WhatsApp use would allow in terms of education and learning, then of course the group number needs to be much smaller. And we have worked with participants in groups ranging from 20 to 30, 35 participants. I think this is a very good number where you still can really engage in meaningful discussion and learning. But it's just about the information dissemination, then of course many more can take part in such a group.
Great, that's helpful. I would love to have all of social media for global health on one WhatsApp group, but that would be entirely large.
I think there was one exception, because the WhatsApp groups they tend to be limited, but I think it was during the Ebola crisis that where information had to be disseminated to many users at once, and I think WhatsApp made it possible to have one group with thousands of users just to distribute relevant information. So you may want to ask WhatsApp whether it would make another exception.
That's good to know. Got this question a couple of times from different people. You mentioned gamification to increase engagement on a WhatsApp group, and a couple of our audience members have asked, what platform did you use to administer quizzes and surveys on WhatsApp?
Well, I think the question is very simple. We used WhatsApp. So,
okay.
Because we could have done this much more thoroughly and rigorously in having running a test. But as our activity was absolutely voluntarily, and we really tried to make it very playful, we posted a question onto WhatsApp, and we said this question will be posted tomorrow at 6 o'clock. Then there's quiz time. We called it this fastest finger, and the one who came up first with the best or with the correct answer would then receive this airtime. Of course, if you want to connect WhatsApp discussion with a quiz for which participants should get points or credits for, then you can use any other platform, Moodle or whatsoever, or where you can then automatically you can give responses, automatic responses. You see the points that their participants have achieved. But our approach was really very, very simple. So keep it simple was basically one of our key recipes. But I would agree in settings you would need a more complex tool.
I'll do one last question, and then hand it over to you and then Anne. So every WhatsApp group has a person who keeps the chat muted and never replies, and then every WhatsApp group also has one person that just posts too much and posts about things that are irrelevant. If you have any tips of the trade on how to fix both of those issues, I think that'd be a great question to end on.
Okay. So let's start with the person who never engage. So we are speaking of learners, and this is something which we find in many different social media and other media platforms. And I would fully agree. Activation is key, and in many respects, a vivid group is much better than a muted or a silent group. And we have used, or our moderators have used different strategies. For example, name calling. John, what's your take on this? For example, or what's really relevant is to be responsive. So if someone responds, then you should acknowledge her or his answer, comment on this. So moderation is a challenging task. So you have to keep focus. What our moderators also did was addressing quiet persons outside of the group, asking them why they wouldn't participate, whether there was a particular reason, to better understand their non-engagement. And so this is how we really try to keep our groups engaged. But lurking is something with which we also have to live to a certain extent. And we have, like in any other media, we have lurkers. And in that respect, I think one of our research results is quite interesting that we gained from the last study, which we submitted now. And this says that the level of individual active contribution not what brings or what creates success or successful outcomes. In other words, individuals who write more on WhatsApp, and we have measured this, not by self-reported, but by measured, we've counted their engagement. So individuals who write more do not necessarily or do not have more benefits in terms of knowledge or in terms of socio-professional indicators. And so it's really more about the depth of engagement and reflection, not its quantity of active contribution, which then makes the difference. And in some cases, or we have just to say that these lurkers are also benefiting. Also, we need to see that a group which is made up only of lurkers would certainly not work.
Great, Christoph, thank you so much. And that is time. Thank you, everyone, for the engaged and thoughtful chat box discussion. And on behalf of Social Media Global Health and Libby, I want to thank Christoph for his time. We heard some really interesting things today, and just some of the highlights include that WhatsApp instant messaging enables intimacy, immediacy, and ownership, and this is hugely important for training because you want your group members to trust each other, respond quickly to each other, and be accountable to the group. We learned that WhatsApp is a social platform and successful groups stay authentic to the platform. That means moderators have to strike a balance between keeping the group focused but still allowing conversations and social interactions to happen. And the ideal number for a group, if goal is meaningful conversation, is around 30 to 35 members. And finally, group members may share information that violates client privacy and confidentiality, or information that devices fake news. As a moderator, you can and should embed some skill-based questions or lessons within your training to help your members learn to identify and combat misinformation. And Christoph offered some practical resources where you can draw examples from. This was a really engaged group with a ton of questions, and I know we weren't able to answer them all. If you want to continue the discussion, Christoph's contact information is on screen, and you can also post questions on Twitter by tagging at SM4GH. We will post today's recording on the K4Health YouTube page in the next week or so. If you are not already part of Social Media for Global Health, you can join us at the link in the first couple of slides in this webinar, or also follow us on Twitter. And finally, if you follow our Eventbrite organizer page, you will receive an email when we post our next webinar. Thank you all so much for joining. Thank you for staying on for the recap, and I hope you have a wonderful morning or evening wherever you are.
Thank you so much, and bye-bye from Switzerland.